My name is Bob Wilson. I am an interventional pain management physician, and I just began doing a new procedure that just is new to the area. I'm the first one in the Charlotte metro area to do this procedure, and it's called a minimally invasive lumbar decompression. What that involves is reducing some of the spinal stenosis that patients have. Now, generally speaking, this procedure is designed for patients who are not good open surgical candidates of lumbar spine. There are patients generally average age of 70 years of age. They have symptoms usually that involve lower back and hip and some leg pain. What I'm able to do with this procedure, and it is an outpatient procedure, generally takes about an hour or so to do, is to insert a small portal, an endoscope that I work through, about the size of a baby aspirin in diameter. I insert it into the spine after localizing the skin, and the patient is awake but sedated. And I can go into this portal, through this portal, and remove tissue. And the tissue is this dense ligamentum flavum that patients develop over time. You have to understand that the spine itself is well made and works well when we're all younger. As we grow older, things occur. Degenerative disc problems occur, and the symptoms again of this stenosis, a common one is neurogenic claudication. A typical patient who has this symptom of neurogenic claudication will be able to walk for 5, 10, or 15 minutes, and then they'll find themselves having to sit and rest. They'll feel better during that period of time. They'll get up and walk again for 10 to 15 minutes and have to sit and rest again. What happens is the nerve endings in the spinal column get crowded and swollen, and they have to rest to get the blood supply back to them and to be able to feel good again. By removing some of this dense ligament that is part of the posterior elements of the spine, we can then widen the canal, the spinal canal that is already tightened by this. As well, part of the procedure is to remove a small amount of bone called lamina, but the main focus of the procedure is just to remove enough lamina to get to this dense tissue of ligament and remove that. And generally speaking, the procedure again takes about an hour to do. What we find is that patients anywhere from 2 days to 3 or 4 weeks will notice a change. One of the first patients I took care of in 2 days, she felt good enough to go out to her mailbox and back, which she hadn't been able to do without stopping and resting. And the equipment for it is made by a company called Vertos in California. It was FDA approved, I believe, 2 years ago now, and we have seen over 10,000 patients who've had this procedure performed, and to date there's been no complications from the procedure. There are complications that can and may occur over time, but because this is such a less invasive procedure than an open laminectomy procedure, let's say, or a fusion procedure, the risk of infection is much, much less. The risk of what we call a dural tear that can cause a headache and things like this postoperatively is again yet to be seen. Again, it needs to be performed by providers, medical providers like myself, who have been trained in the procedure, who find that the right patient needs to be selected by those same physicians. Again, the skill set to perform the procedure is not unlike what we have every day for other types of interventional pain management procedures that we have. It is a step further, I would have to say, but again, picking the right patients, knowing the anatomy like we know it, and performing this FDA-approved procedure, again, has proven beneficial to a lot of patients. What we look for is a patient who has MRI evidence of this dense ligamentum flavum tissue and has classic symptoms of neurogenic claudication. Sometimes patients present with also what we call radicular pain or sciatic pain. This procedure in particular isn't designed to help that as much, although if you have crowding of the nerve elements inside the spinal canal, often you'll see an improvement in the leg pain that people have as well. But again, different types of procedures, a different type of surgery by a surgeon would help that more if those symptoms persist. So this particular mild procedure is something that's performed 90–95% of the time by interventional pain management physicians like myself. It is designed to work, again, in an outpatient setting. There are a few spine surgeons that utilize this as well, but the reality is that most people doing this are not spine surgeons like myself. My background is interventional pain, trying to do procedures through needles and smaller devices without open procedures. So what we find in these patients is that we're able to take a patient that a couple of years ago didn't have a good option for them. They were told by a surgeon that they have too many other health problems, whether it be a bad heart, lungs, kidneys, livers, things like that, that they are not a good candidate to undergo general anesthesia for 2 to 4 hours for an open laminectomy or open procedure. And they've been told they just have to live with the pain. They'll come to my clinic. My usual routine is to go through a couple of different injections to see if we can get them better, and if they do, that's great. We now have a procedure, and all 8 of these patients that I've recently performed the procedure on have went through my procedures. They got very short-term benefit, maybe a week or 2 from epidural injections or facet joint injections or what we call facet rhizotomy procedures, all having continued back pain and all having symptoms of neurogenic claudication. Now we can do this procedure on patients, and in reality, the patients I perform these on, I just don't have to make return appointments for. All of them have done well enough that they've not had to come back to my clinic. In time, it may be that we'll see these people again. It may be that they'll have some more back pain that occurs, but my hope is, and statistically what we see is when they do return, if we do those same epidural injections to calm down irritation causing back pain, we'll find that they'll get a longer, better lasting benefit from those procedures. But most patients are able to stop seeing pain management physicians like myself for a good period of time, maybe forever. And certainly my experience with it so far has been that the patients are feeling quite a bit better and again have not had to return to see me. Again, I'm taking patients that I get calls from on a monthly basis who I'd have to call and see for medication therapy or another injection, who now don't seem to need me for any further pain care. So I look at that. Any physician looks for a procedure or a medication that will help patients and make it where they don't have to see their doctors often. Our whole goal in pain management is to keep patients as functional as we can. In this country, we have a very aging population. It wasn't that many years ago the average lifespan of an adult in America was 60, 65, 70 years. Now we see patients living to be, again, my oldest patient in my practice is 102. I have other patients well in their 80s performing procedures on them. Not every one of these patients are right for this particular procedure, but I certainly have a large volume of patients who are candidates for this, and each day we find more and more patients, and we look for more and more of these patients who have these sort of symptoms, who have the MRIs that show the pathology we look for, and again are being helped by